All right, we are going to start our grand round today. Thank you all for joining in. Our speaker today is Dr. Sharon Nofec-Mozes, an associate professor at the University of Toronto. Dr. Nofec-Mozes received her medical degree from the University of Tel Aviv, where she did her residency training in anatomic pathology. She moved with her family to Canada, Toronto. She did breast and GYN fellowship with us in Sunnybrook Hospital. She came on staff as an assistant professor and made her way through the ranks. Dr. Nofec-Mozes is a well-established researcher, leader, administrator, teacher, and a great diagnostician. As a leader, Dr. Nofec-Mozes was the lead pathologist in a major project undertaken by the government of Ontario, known as the Rapid Diagnostic Unit, or RDU. It took maybe, 4 or 5 years to build that center. It's a unique center, still is the largest and the first one in the entire country, where the patient shows up in the morning, 8 a.m. with a suspicious breast mass. She gets the imaging, the examination, the core biopsy, the diagnosis, everything, and biomarkers and everything. And by next day, she already has a plan. She met an oncologist and everything is laid out for her. It was a great project, just one of many examples of what can be done in a universal healthcare system. And Dr. Nofec-Mozes took advantage of that. As a researcher, she was the lead pathologist on the province-wide DCIS project. I guess she will talk to us about it today. And I think it's the largest cohort known to us till this day. She has so many publications. She won teaching awards, and she spoke in many meetings. One of them was our ET Bell a few years back. She accepted our invitation and she spoke with us. So now I will turn it on to Sharon, and we look forward to hearing your talk, Sharon. Thank you.
Thank you very much, Mahmoud, for the kind introduction. I don't know if I deserve everything, but we will start with a presentation. So in the next 50 minutes, I will present an update on DCIS, and I'm going to focus on current challenges and review some of the research work that I'm involved in. Let me see how I proceed with that. Okay, the Ontario DCIS cohort research was funded by CCSRI, CBCF, and Sunnybrook Research Institute had a research contract with Genomic Health, now known as Exact Sciences. So the objectives for today will be to review basic pathology regarding specimen processing and histopathologic features of DCIS, discuss some management options, review current tools to triage DCIS patients according to their risk of recurrence and treatment benefits. I would like to share with you some lessons learned from the DCIS Ontario cohort studies, and to highlight some new items to look for in the pathology report, and talk a little bit about the future directions. The breast consists of a system of glandular tissue that includes lobular units that produce milk during lactation. The glandular or epithelial component is made of ducts connecting the lobular units to the main lactiferous ducts that open to the nipple. The glandular tissue sits in a supporting stroma that is made most mostly of fat and other connective tissue elements. DCIS is defined in the WHO classification as a neoplastic proliferation of the mammary ductal epithelial cells confined to the ductal lobular system. This proliferation is separated and guarded from the surrounding stroma by the basement membrane and a peripheral layer of myoepithelial cells. DCIS is morphologically heterogeneous. It comes in different shapes, patterns, and grades. Currently, we recognize 3 grades based on nuclear features, with low grade being well differentiated and high grade the least differentiated, the furthest away from the look of a normal epithelium. We also recognize different architectural growth patterns, such as cribriform with rounded secondary lumens with polarization around those secondary lumens, or solid, but also not shown here, papillary, micropapillary, and flat subtypes. Many cases are associated with calcifications. These calcifications are often the reason that lead to the diagnosis of DCIS on screening mammography. Here are 2 examples of calcifications with low and high-grade DCIS. Some of the DCIS will have an area of central necrosis known as Comido-type necrosis. So in the next 3 slides, I want to invite you to join me to the pathology lab. Here is an example of mastectomy specimen. When the fresh specimen is received in the lab, the resection margins are inked in different colors, serially sectioned, fixed in formalin for at least 24 hours, and a gross examination is made. In selected cases, X-ray to identify the target lesion or a clip may be undertaken, and representative sections are submitted for microscopic evaluation, and hopefully a grossing diagram is created. In our lab, we have a high definition gross camera, and we mark the blocks allocation as you see below. The tissue is then put in cassettes, placed in tissue processor, and in Canada it's done overnight. So the next day the tissue is embedded in paraffin to create blocks, and we obtain 5-micron sections that are cut and stained by H&E. So after your speedy visit to our pathology lab, let us move our attention to 2 examples. So here are 2 scenarios. The first is a 67-year-old woman that has screening mammography that revealed 8mm area of calcifications in her right breast. Biopsy showed intermediate grade DCIS. The second case is a 38-year-old. She palpated a 1.5 centimeter mass in her right breast at 3 o'clock, and breast imaging demonstrated another area of 1 centimeter of calcifications at 7 o'clock. Biopsy from both sides showed intermediate grade ductal carcinoma in situ. So the same pathology report, but different clinical setting. So our approach clinically could be different. There may be many questions, but the first one that comes to mind would be, is DCIS considered cancer? So according to the NCI website, cancerous tumors spread into or invade nearby tissues and can travel to distant places in the body to form new tumors, what we call metastases. So for the general population, it means a disease that can cause death. DCIS, on the other hand, is listed on that website as tissue changes that are not cancer because the abnormal cells cannot invade. That's true, but in DCIS, abnormal cells are proliferating in the ductal system in the pure form. but it has, in that pure form, it has no access to the stroma, lymphatics, or blood vessels. But if these abnormal cells will gain a capacity to invade through the basement membrane and infiltrate, it can cause death. So how likely is DCIS to progress? How long it takes? We will try to address some of these questions. The incidence of DCIS has risen sharply in the era of mammographic screening and now represents approximately 25% of all breast cancer diagnoses. Most cases are detected as calcifications by screening mammography. Autopsy studies report that up to 15% of women who died of causes unrelated to breast cancer have evidence of DCIS in the breast, which never clinically manifested as disease during their lifetime. This suggests that there are likely cases that would never become clinically relevant. There is very little information available about the natural history of DCIS, because if a diagnosis of DCIS is being made, the patient is going to have some type of therapy. The most direct evidence regarding the progression of DCIS to invasive cancer comes from older studies where DCIS was initially misdiagnosed as benign and treated by biopsy alone. These studies suggest that between 14 to 53% of DCIS may progress to invasive cancer over a period of 10 or more years. The autopsy studies also suggest that a larger reservoir of DCIS may exist in the population. We also know that invasive recurrence is associated with decreased survival. In a recent publication led by Alistair Thompson based on UK data, the outcome of patients who were diagnosed with DCIS but had no record of breast surgery was investigated. The risk of developing ipsilateral invasive carcinoma at 10 years was 9% for low grade, compared to much higher grade to intermediate and high grade at 39 and 36%. The risk was higher in younger women, larger lesions, and cases with microinvasion. So most scientists view it as a non-obligatory precursor of invasive cancer. The current NCCN guidelines recommended treatment options are based on primary surgical treatment, and the surgical options include mastectomy with or without sentinel lymph node biopsy, lumpectomy with radiation, or lumpectomy alone with the potential addition of tamoxifen for hormone receptor positive DCIS. Let's focus for a minute on the surgical management. At present, surgical excision is considered a standard of care. The first decision would be to decide whether to remove only the area of the abnormality through a breast-conserving surgery or remove the entire breast. Areas of controversies also include what is considered adequate margins, should sentinel lymph node be included, and whether nipple-sparing mastectomy is appropriate. Until the early 1990s, mastectomy was the standard of treatment for patients with DCIS. However, when women with invasive breast cancer were offered lumpectomy followed by adjuvant radiation in the late 1980s and early 1990s, it seems paradoxical to treat patients with a non-invasive disease with mastectomy. Interestingly, no randomized clinical trial has ever compared mastectomy to breast-conserving surgery and radiation therapy in women with DCIS. The C registry was queried for patients diagnosed with DCIS between 1991 and 2010, and treatment pattern trends were analyzed. During this period, there was a decline in rate of mastectomy and increased rates of breast-conserving surgery, particularly with radiation therapy. We will move on to the role of radiation therapy. There are four large-scale prospective randomized trials looking at the benefit of radiation therapy for patients with DCIS. You will notice that in these randomized trials, the majority or even all the patient had mammographically detected DCIS. In combined analysis of these trials, the use of radiation therapy results in 50% reduction of any type of recurrence, invasive recurrence, and in situ recurrence. However, when looking at the ultimate goal of treatment, at 10 years, the overall survival was not significantly different between patients receiving radiation or those who did not. None of the randomized clinical trials identified subgroups of women who were not benefiting from radiation therapy. With no survival benefit, the goal of radiation therapy is local control. Remember this when we will review the analysis of the Ontario cohort. I will try to challenge it. This is already an older study, but it's still good to demonstrate the point. The way to look at this graph, the way it's set up, is that margin status are shown here at the x-axis. Here is nuclear grade, and the y-axis is the percentage of academic physicians recommending radiation therapy. So you can see here that for for high grade, the majority of physicians will recommend radiation therapy. However, for low grade, less than half of physicians recommend radiation therapy if the margins are wide. How about endocrine therapy? The randomized trial SABP-B24 demonstrated that the addition of tamoxifen to the combination of breast-conserving surgery and RT reduced the risk of local recurrence by about 30%, and that the benefit of tamoxifen was limited to women whose DCIS was ER positive. In the UK study, the benefit of tamoxifen became evident only in the long-term outcome analysis. Other studies have shown that aromatase inhibitor, such as anastrozole, similarly reduced the risk of local recurrence in women with DCIS treated with breast-conserving surgery and radiation therapy. So endocrine therapy is an option for women desiring to minimize as much as possible their future risk of breast cancer. Most favorable risk-benefit ratio is actually in premenopausal women with 2 breasts. And because the absolute risk is low for DCIS in general, it is not viewed as a necessity. In our center, most patients with DCIS are not offered tamoxifen. The notion that patients with low-risk DCIS can be treated with breast-conserving surgery and forgo radiation therapy was studied in the ECOG 5194, a randomized trial of low-risk DCIS. Participants were treated with breast-conserving surgery without radiation therapy, with or without tamoxifen, based on patients' and physicians' choice. These were mostly very small lesions, with half of the patients having wide, clear margins. At 5 years, local recurrence was relatively low for low grade, but with additional 2 years of follow-up, local recurrence significantly raised in the low-grade tumors, suggesting that breast-conserving surgery alone may not be safe for low-grade, even in this highly selected study of small lesions with wide resection margins. This observation about the time to recurrence have been shown also by others. So for low grade, it takes longer to recur, but the ultimate risk at 10 years is the same across grades. This is another prospective randomized trial of low-risk patients with very similar inclusion criteria to the ECOG 5194. It demonstrated that at 5 years, there was significantly higher local recurrence rate in patients not receiving radiation therapy. So traditional histopathological factors are insufficient for identifying patients with no benefit from radiotherapy in terms of local control. It became clear that we're probably overtreating many women with DCIS, but possibly undertreating others. So the questions are, can we identify low-risk group that can be treated with breast-conserving surgery alone? Maybe there are patients with super low risk that can go for active surveillance. These two are often overtreated based on standard of care. On the other hand, can we identify patients in whom the risk remains high even with radiation therapy? These patients are often undertreated. So these questions set the stage for my research interest. In this part of my talk, I will share with you some of the research projects that I took part in. The Ontario population-based cohort represents individuals diagnosed in the province of Ontario with DCIS between 1994 and 2003. Patients were identified via data mining of about 130,000 breast pathology reports with a final diagnosis of ductal carcinoma in situ. By linking the Ontario Cancer Registry, patients were excluded if they had had a previous invasive cancer diagnosis. Treatment and outcomes were validated through primary chart review, operative reports to validate surgical management, and radiation reports. Expert breast pathologists centrally reviewed the slides. Overall, we identified 3,320 women with pure DCIS, that about half of them had breast-conserving surgery alone and half breast-conserving surgery followed by adjuvant radiation. But just remember, this is not prospective or randomized trial. This is population-based, so they were selected for radiation. Pathology was centrally reviewed for focality, size, grade, subtype, comedonecrosis, and clear margins. A group of 14 pathologists with special interest in breast pathology met in 2008 and prospectively defined criteria for centralized pathology review. A limited group of study expert breast pathologists review the pathology of either resection specimens or the core biopsies in cases with no residual disease on excisions, and re-excision specimens when applicable. All the available original slides or recuts from the entire case were included in the review. De-identified copies of the original gross description were available at the time of pathology review and were used to determine the spatial relationship between slides of DCIS. Overall, centralized pathology review was completed on 82% of the women. Positive margins were defined as tumor on ink or cauterized tumor, like in the upper panel, and the lower panel shows DCIS with margins over 2 millimeters away from the tumor. Multifocality was defined as ducts with DCIS that are separated by at least 5 millimeters of benign tissue, and this could be either on one slice or across non-sequential slices of a serially sectioned specimen. I would like to share with you some of the main projects so far. Validation of the 12-gene DS score, predictors of breast cancer mortalities, study on the effect of single versus multiple foci of microinvasion, and the effect of tumor size. The DCIS score analyzes 7 cancer-related genes derived from the Oncotype assay for invasive breast carcinoma. They represent mainly progesterone receptor and proliferation-related genes. This is compared with the 21 gene assay that also takes into consideration ER and HER2. It provides individualized estimates of the 10-year risk of local recurrence in patients with DCIS treated by breast-conserving surgery alone, without radiation. Prior to our study, the 12-gene score was tested in the ECOG 5194 cohort of clinically low-risk patients. Among 327 cases that were tested, 230 found to have low DCIS score, projecting 10.6% of local recurrence events at 10 years. The difference between the low score and intermediate and high scores were statistically significant. The primary objectives of this part of our study was to determine the relationship between the risk of local recurrence and the DCIS score in patients treated with breast-conserving surgery alone and negative margins. Similarly, in the subgroup that received radiation, and the secondary objectives were to evaluate if DCIS score is independently associated with local recurrence in patients treated by breast-conserving surgery and radiation therapy, adjusting for significant clinical and pathological factors, and to evaluate the effect of radiation therapy by DCIS risk score. Available blocks from 718 patients in the breast-conserving surgery alone group and 846 patients among patients that were treated with breast-conserving surgery and radiation therapy were analyzed. These are the characteristics of the patients. So first, I want to draw your attention that in real life, outside of clinical trials, low-grade DCIS accounts for less than 10% of patients, and multifocality was found in 21 and 26% of patients. With a follow-up of just over 9 years, we had 100 local recurrences in patients treated by breast-conserving surgery alone with clear margins, and 86 local recurrences in patients that had radiation therapy. The 10-year Kaplan-Meier risk of local recurrence was 19 and 12%. Multivariate analysis of factors associated with local recurrence in the Ontario cohort among patients treated with breast-conserving surgery who had clear margins were age over 50, size over 1 centimeter, multifocality, non-cribriform architecture, the DCIS score, and radiation therapy significantly reduced the risk of local recurrence. Similar to the ECOG 5194 trial among the breast-conserving surgery alone group, the assay identified a low-risk group that has significantly lower risk of any local recurrence at 10 years compared to patients with intermediate or high recurrence score. Here are the DCIS score results across clinical and pathological characteristics. DCIS score results were widely distributed within each subgroup defined by the clinical and pathology characteristics. The score was only moderately correlated with clinical pathological variables. So, for example, cases with high grade did not have only high-risk score. And among grade 2s, in fact, the majority had a low-risk score. Patients who received radiation therapy, shown here in the broken line, had a lower risk of recurrence with an overall hazard ratio of 0.5. However, we can see that the two lines are not entirely parallel. The absolute benefit was smaller in low-risk DCIS score compared to greater absolute benefit for patients with high-risk DCIS score. We found that women younger than 50 at diagnosis, tumor size over 25 millimeter, presence of multifocality, positive margins, and DCIS score were significantly predictors of local recurrence in propensity-adjusted multivariate analysis, and individuals with multiple high-risk features experienced a higher risk of local recurrence, particularly with those with high-risk DCIS score. Although the risk was lowered with radiation therapy, further research is needed to determine the optimal treatment for women with multiple high-risk features. Among women 50 or younger with multifocal disease and high-risk score, 1/3 experienced recurrence even after radiation therapy. Similarly, about 1/3 of young patients with tumors that are larger than 2.5 centimeter recurred. More recently, we performed a meta-analysis combining data from these two cohorts, the ECOG and the Ontario population-based cohort, and attempted to further refine the risk estimates provided by the 12-gene DCIS score and clinical pathological features. We identified a low-risk group at 10 years with local recurrence rate of 7.2%. This low estimate is based on the combination of age 50 or older at diagnosis, tumors that are smaller than 1 centimeter, and low score. The next question would be, is the assay useful? A previous study by Alvarado et al. Evaluated the influence of the test in 10 centers in the United States using data from 115 patients. The DCIS score led to a change in the treatment recommendation in 36 patients, so that's about 30%. 26 patients had a change to no radiation, and 10 patients had a change to recommend radiation. Another study, a prospective non-randomized trial by the acronym DCIS in Canada, assessed the impact of the DCIS score on clinical practice in 217 patients, and change in treatment recommendation occurred in 76 patients, accounting for 35% of patients. Radiation therapy recommendations decreased from 79% pre-assay to 50% post-assay. The assay was associated with improved patient satisfaction and reduced decisional conflict. Another national prospective single-arm cohort study is just open in Canada to further assess the outcome of clinically low-risk DCIS with low recurrence score. We then analyzed the risk of breast cancer mortality in 1,300 individuals of DCIS, 75 years or younger at diagnosis, treated with breast-conserving surgery. We examined the association between high recurrence score, this time using the 21 gene assay, the one that is also known as Oncotype DX. The risk of breast cancer mortality accounting for the competing risk of death from other causes. With 16 years median follow-up, 36 died of breast cancer and 200 patients died of other causes. High recurrence score was observed in almost 30% of the patients who died. A high recurrence score was associated with 11-fold increased risk of breast cancer mortality in women aged 50 years or younger at diagnosis that were treated with breast-conserving surgery alone. There was no association between death and high recurrence score in the group that had adjuvant radiation. We found that the 21, not the 12 gene assay that we discussed previously, predicts breast cancer mortality in women under 50. Radiation therapy was associated with 71 relative reduction in the 20-year risk of death among patients 50 or younger with high recurrence score. I want to draw your attention that we provide here the first evidence that radiation therapy may affect overall survival in women diagnosed with DCIS. We further looked at the significance of finding DCIS with microinvasion. Microinvasion is defined as presence of malignant cells in the stroma in an area smaller than 1 millimeter. The current definition is not distinguishing between single focus and multiple foci of microinvasion, and the number of foci are not routinely reported. In this analysis, we compared the outcomes of cases with pure DCIS and DCIS with microinvasion among patients treated with breast-conserving surgery with or without the addition of radiation. We compared the outcomes of patients with one focus of microinvasion and those with multiple foci of microinvasion. The cohort included overall 2,988 women treated by breast-conserving surgery, 2,721 had pure DCIS, and half of them got radiation. 267 had DCIS with one or more foci of microinvasion, and these patients got 58% of these patients had adjuvant radiation. On multivariable analysis, the presence of multiple foci of microinvasion was associated with an increased risk of invasive but not in situ recurrence. The 15-year invasive local recurrence-free survival risk for cases with multiple foci of microinvasion increased from 74% to 95% for women treated with breast-conserving surgery with radiation and boost. Kaplan-Meier curves shows survival benefit for patients with multiple foci of microinvasion who received whole breast radiation and boost. In conclusion, the presence of multiple foci of microinvasion in DCIS is associated with higher 15-year risk of invasive local recurrence after breast-conserving surgery compared to patients with pure DCIS, but treatment with whole breast radiation and boost can mitigate that risk. Using the Ontario cohort, we also looked at the outcomes of large DCIS treated with breast-conserving surgery with large tumors defined as 4 centimeters or larger. The risk of local recurrence following breast-conserving surgery was significantly higher for larger tumors, and that is of no surprise. The hazard ratio for tumors 4 centimeter or greater was 3.67. However, larger tumor size was not associated with significantly increased risk of local recurrence if the patients were irradiated. So long-term recurrence-free survival rates can be achieved with the addition of breast cancer, with breast radiation, and the boost did not significantly change the outcome in this analysis. So the 12-gene DCIS score could help identify patients at low risk of local recurrence. But are there any other signatures? Can we identify patients that are more likely to respond to radiation therapy? Here comes the Decision RT assay by Prelude. It combines immunohistochemistry and clinical pathological features. The IDC panel includes HER2, PR, Ki67, COX2, P16, FOXA1, and SIA-H2. These are stained and scored centrally in Prelude's diagnosis lab. Continuous decision score, or DS, are calculated with the biological signature using the immunohistochemical markers as well as age, size, margin, and palpability. The assay stratifies patients to low versus elevated risk groups with a cutoff at 3. The assay is marketed as prognostic and predictive. I personally think that it's mostly prognostic, but is also it may help with the decision on radiation therapy. The Swedish group presented at San Antonio their results in 2017 in an abstract format, and the manuscript followed only this last December, so it took about 4 years to publish. The signature was tested retrospectively in a prospective study of 1,046 patients. And the 10-year benefit from radiation therapy was analyzed on cases with available blocks. And this was in about 40% or 50% of the cohort. For patients with high DS score, elevated risk group, with a DS score over 3, there was significant benefit from radiation therapy at 10 years, with an absolute risk reduction of 9% for invasive local recurrence. The corresponding low-risk group with score 3 or under, which included 48% of all patients, demonstrated no significant radiation therapy benefit with an absolute risk reduction of 1%. The assay was subjected to independent validation using 455 patients from the KPNW Integrated Health Plan diagnosed with DCIS and treated with breast-conserving surgery with or without radiotherapy from 1990 to 2007. The Decision RT results, or DS score, was associated with any local recurrence and invasive local recurrence adjusted to RT. In this study, margins were analyzed as positive, tumor on ink, versus negative, and multifocality was defined similar to the Ontario cohort with 5 millimeter of intervening benign tissue between foci. Tumor size was recorded based on the largest extent as indicated on the original pathology report. After adjusting to radiation therapy, there was significant association between the decision score as a continuous and categorical variable and any recurrence and invasive recurrence. This study provides the first external validation of the assay as a prognostic test. Exploratory analyses are reported, although the study was not powered to detect significant difference within radiation therapy groups. And although not statistically significant, the benefit from RT was larger in patients with elevated risk. The clinical utility of DecisionRT assay was examined in the PREDICT study funded by Prelude. 539 patients with DCIS were enrolled in the prospective multi-US institutional registry. The change in proportion of DCIS patients recommended adjuvant radiation therapy was examined. Overall, prior to testing, adjuvant radiation therapy was recommended in 69% of patients. This number dropped to 49% based on the decision results. In 46%, the assay changed the recommendation not to radiate, and in 35%, the change was to the other direction, from no RT to RT, for an overall 42% change in the original recommendations. In this analysis, Dr. Rakovich looked at the distribution of ipsilateral breast events over time. The blue solid line represents patients treated with breast-conserving surgery without radiation, and the red broken line, the patients who received adjuvant radiation. The upper left graph plots any recurrence. Most events really occurred in the first 3 years. Those are mostly mitigated by radiation, with the red line representing disease that is probably resistant to radiotherapy. But after the 7-year mark, those line overlaps. Based on this analysis, some believe that the early events are regrowth of residual tumor, whereas the late events are new tumors. The trend is similar for both invasive and in situ disease. As you can see on the right lower graph, the lines overlap completely when the contralateral events are plotted. So we have shown that the addition of any of the prognostic assays appears to impact selection of patients for adjuvant radiation therapy, but no head-to-head comparison has been made between the DecisionRT and the 12-gene assay. Refined prognostic signatures are still desired, and predictive assay to predict benefit from radiation therapy is still pending. Are there any patients with very low risk that can be watched only? We're currently waiting for results from 4 clinical trials testing the possibility to avoid surgical resections altogether for low-risk mammographically detected DCIS. Eligibility criteria vary slightly among the studies, but generally target low-risk patients with screen-detected DCIS with calcifications. The LORIS trial in the United Kingdom, LORD trial in continental Europe, COMET trial in US, and LORETA, a single-arm study in Japan. The LORIS, a UK study, was the first one, was meant to be a multi-center randomized controlled trial phase 3 that would randomize 1-to-1 surgery versus active monitoring in patients with low-risk DCIS. It was designed to assess whether active monitoring is non-inferior to surgery in terms of invasive ipsilateral breast cancer-free survival at 5 years. The COMET trial compared DCIS treated with surgery with or without radiation and a choice for endocrine therapy versus active surveillance with a choice of endocrine therapy. Notably, comedonecrosis is allowed in the COMET trial in the inclusion criteria. The primary outcome is the proportion of newly diagnosed ipsilateral invasive carcinoma in the control and active surveillance arm at 2 years, and the rates of invasive cancer at 5, 7, and 10 years will also be evaluated. So the situation is that there is a dramatic challenge in accrual for these trials. So the LORIS and LORD trials were recently converted to registries due to low accrual in Europe. As of a year ago, COMET enrolled just less than half of the targeted patients. So while we're still waiting for the real outcomes from active surveillance trials, a group from Japan looked at the upstage rates on excision among 152 women who were diagnosed with DCIS on core and would have met the inclusion criteria for one of the active surveillance trials. Invasive carcinoma was identified in 12 to 25% of patients on excision. Most of the occult invasive cancer admittedly were small, 5 millimeters or smaller. But this study highlights the limited ability to appropriately select patients with very low risk for active surveillance based on the available tools. So I hope that we may have some answers to our women, and certainly we have certain options. So the first woman is a postmenopausal with screen-detected small DCIS, and the second lady has several risk factors. She is younger than 50, she has a multifocal disease, she has a mass lesion that is palpable, and a tumor over a centimeter. So for the first woman, we will probably recommend breast conserving surgery. There is a reasonable chance that any of these prognostic signatures will show a low risk if she has access to those. If this is the case, she may decide that her absolute benefit from radiation therapy is minimal and choose to forgo radiation therapy. On the other hand, the second lady has several risk factors. She is eligible for genetic testing for BRCA. Depending on the location of the two tumors and the size of her breast, she may be able to get a reasonable cosmesis with breast conserving surgery and radiation, or elect for mastectomy. In our center, we would almost certainly be offering mastectomy for such a young patient with so many risk factors. Nevertheless, a patient elected to have a breast conserving surgery, and her final pathology showed 2 foci of DCIS, one with 3 foci of stromal microinvasion and negative margins. ER was positive. So for this lady, we will now offer sentinel lymph node biopsy. In terms of radiation therapy, she will certainly be recommended whole breast radiation, and most likely will be offered a boost. And since she is premenopausal and has 2 breasts, endocrine therapy is certainly something to consider. So in conclusion, DCIS is a non-obligatory breast cancer precursor. It is associated with low rates of mortality. Radiation therapy reduces local recurrence rates for all patients. Traditional histopathological characteristics are limited in predicting risk of local recurrence or benefit from radiation therapy. Independent risk factors include age, size, multifocality, histologic type, and positive margins. I just want to underscore that grade is not here. Women over 50 with smaller tumors than 1 centimeter, unifocal disease, and low 12-gene DS score have less than 10% risk of local recurrence. The Decision RT is another available assay validated as a prognostic tool and pending additional validation as predictive signature. Challenges are limiting enrollment to randomized trials for active surveillance. And overall, after all this work, we're still looking for a robust tool to help with individual risk assessment. So thank you for attending, and I'm happy to answer questions.
Thank you, Sharon, again for wonderful presentation. I apologize, I rushed for a frozen section, and I did not mention that Dr. Nofec-Mozes is also the chair of the promotion committee for the department at the University of Toronto. Great presentation. Thank you, Sharon. Any questions for Dr. Nofec-Mozes?
I have a question.
Go ahead.
Hi, this is Molly Klein. I'm one of the breast pathologists at the U. And thank you, really. I want to reiterate what Dr. Khalifa said, just a wonderful talk. It was great for me and certainly for all of us, including the trainees. I will expect them to know everything about DCIS from now on. Because you really covered it all. Thank you. There's so many issues that you raised in your talk. One question I had specifically about that very large study that you did of assessing DCIS risk of local recurrence without radiation using the 12-gene assay. Were those patients, was there an analysis of the effect of endocrine therapy in those patients, whether or not they received endocrine therapy as a possible factor in the risk of local recurrence?
Yeah, so actually, this is a very good point, and I need to explain that our cancer registry, because the way health services is distributed in Ontario has limited data available for tamoxifen treatment in patients under 60. So with that caveat, I can tell you that less than 5% of the cohort received tamoxifen. So with the limitation that is actually unknown for patients younger than 60, they are more likely to be prescribed tamoxifen. So in fact, this is one of the weaknesses of our cohort. So I can't answer your question whether patients with low risk benefited from it.
That is a good answer to the question. I'm surprised that small percentage of patients received endocrine therapy. It's very interesting. Thank you.
Yeah.
Hey, Sharon. This is Andy Nelson. I'm a molecular pathologist and a breast cancer biologist. Don't really call myself an anatomic pathologist anymore, but technically I'm board certified in that too.
That's okay. That's okay.
Work very closely with Molly and some aspects of the breast cancer translational working group here. So again, thank you for a fantastic talk. And I mean, the ability to do this type of long-term longitudinal research is just amazing. And I hope everybody, including our trainees, understands how challenging it is. DCIS research is very challenging. I have two questions, if you don't mind. The first is regarding pregnancy-associated breast cancer and age, and you had a lot of details in the studies as you presented, and I apologize if I missed some of these. But pregnancy-associated breast cancer is, of course, an entirely different beast, and there is a small but not insignificant number of women who present with isolated DCIS but extensive DCIS within that first 10-year window post their last pregnancy. any sense of kind of how that impacts, or if you guys even have enough numbers across the cohorts that you described to look at that aspect of the question?
We actually never looked at it. I certainly not sure how we can do that, but we can. It's a good point. We never asked ourselves that question.
Yeah, and so it springs into the fact with that other immunohistochemical signature, which I also found fascinating, and I actually hadn't been aware of that one, because COX-2 and inflammation associated with remodeling during involution is likely part of that process. And I've worked with people like Pepper Shadeen and Ginger Borges, Tracy Lyons, and that's kind of how I've been pulled into that world. And what I find interesting about that signature is, at least with SIH2, I mean, that's a ubiquitin ligase that's associated with hypoxia. COX-2, of course, is inflammation and stromal. So that is one of the first things that I've seen that's really starting to pull in factors of the stroma. Mm-hmm. Because the problem with oncotype and even the 12 gene signature and other things, it's very tumor centric and it's very much proliferation driven. And that signature, so I'm just curious, when that signature and those markers were developed, was that kind of an empiric scan of large numbers of proteins, or was there some kind of mechanistic picking of those markers as it moved into the clinical validation that you described?
I think this was because I don't have an inside information about the development of the signature, I can only comment to say that the COX-2 and P16, the HER2, all of those were part of a panel that was presented by the Southern Californian cohort. That study had a preliminary data to show that these markers may have an effect. So I think that this is partly why they looked at it. Okay. As a pathologist, I always think that the stroma is telling us a story, whether the stroma is myxoid or whether you have this dense lymphocytic infiltrate around the foci of DCIS, certainly triggers our search for microinvasion. I'm currently involved in a study where we're looking at these stromal factors in the Ontario cohort. Is actually really, really difficult to quantify and characterize, because there is actually heterogeneity in that is more prominent than the actual epithelial component. So in a case with DCIS, sometimes you will have a lot of ducts with periductal lymphocytic infiltrate and some that are not. So it's hard to really quantify that. And also the myxoid. We're also using AI and machine learning to try and do that, because it takes hours, I would say even now, like 3 years to actually do this stromal annotation of images in the Ontario cohort, but hopefully we'll become smarter. And this is one thing where stromal factors are being investigated. And in addition, we're now doing whole genome sequencing of a subset of the cohort. And we are looking at signatures specifically from the stroma, the periductal stroma as well. So hopefully, maybe in 5 years, if I'm not yet retired, Dr. Khalifa will invite me for an update.
Oh, thank you, Sharon. We have to leave it here. Thank you. Thank you so much for the talk, because we are over time, and there is another meeting coming up. Thank you all.
Thank you.
Bye-bye.
Excellent talk. Thank you.